And so at the top, we have randomized trials. This is a very simple hierarchy that stood us quite well for a considerable period of time, but has now been replaced by a much more sophisticated hierarchy, which I will tell you about later in this talk. Next guy that I'm going to introduce you to is Ian Chalmers. For whom in this audience does the name Ian Chalmers mean anything? Okay, maybe a third of the people. Ian Chalmers is the guy responsible for the Cochrane collaboration. The Cochrane collaboration was Ian's idea, and he was the engine to make it happen. How many people in this audience have an idea of what the Cochrane collaboration is? Okay, almost everybody does. All right, so I'm going to illustrate about systematic reviews with this figure. How many people in the audience are basically familiar with these kind of figures? Okay, everybody. Okay, good. All right. So this one is a forest plot, which is what we call these figures, about thrombolytic therapy in patients who've had myocardial infarction. And so, as you are familiar, on the left is represents a reduction in mortality with thrombolytic therapy, and on the right, an increase in mortality. The first randomized trial of thrombolytic therapy occurred in the late 1950s. It enrolled only 23 patients, and so had a very wide confidence interval. The second study enrolled not 65 patients, but 42. This is different from the forest plot you're used to in that it's a cumulative meta-analysis. So as you go down on the left, you see the number of trials and the total number of patients enrolled in all the trials. And you see by 7 trials and under 2,000 patients, the confidence interval is still crossing no effect. So we are uncertain about the effect of thrombolytic therapy. By over 2,000 patients in 10 trials, it doesn't cross. And now the question starts to arise is, have we got enough evidence to start using thrombolytic therapy? Well, if you look down and we now look at 30 trials with over 6,000 patients, we now see the confidence interval is getting much narrower, and it's a long way from crossing, and we're getting very low p-values. And at this point, one might have reasonably concluded we have got enough evidence to know that there's about a 25 reduction in the odds of dying with thrombolytic therapy, and we can stop doing the randomized trials. Did people stop doing the randomized trials? No, they did not. And another 40,000 patients were enrolled after the answer was in, half of whom did not receive the life-prolonging benefits of thrombolytic therapy. Oops. Why did that happen? Why did we have to do that? Well, I think the answer to that question is on the right side of the slide, which shows the recommendations that experts were producing in their textbooks and current journal articles as these data were accumulating. And they go anywhere from routinely recommending thrombolytic therapy, specific indications, experimental, or not mentioning it. 2 things about this. The wide expert disagreement, if you look at the mid to late 1980s, some people saying routine, some specific, some experimental, some not mentioning, and it is a decade after the answer was in that the experts finally have a consensus. And I have talked to the people doing those trials, and they said, the experts wouldn't get it. We just had to keep doing the trials until finally they got it. Unfortunately, there were another 20,000 patients who did not receive the life-prolonging benefits because the cardiology experts didn't get it. Another example, also from myocardial infarction. 45 years ago, I was in training in Toronto. I rotated through the Toronto Western Hospital, and I rotated through the coronary care unit. And in the coronary care unit, when I was in charge of processing and managing the patients at any rate, and everybody who came in the door, we knew that the people after myocardial infarction were at risk of lethal arrhythmias. We knew that lidocaine was a good antiarrhythmic agent, and so I administered what we called a lidocaine drip, an intravenous infusion of lidocaine, to prevent these people from dying of lethal arrhythmias. Was there ever any randomized trial evidence to support what I was doing? No. As it turns out, right from the first trials around 1970 to the trials finally in 1988, the point estimate is on the right, meaning an increase in mortality, not a decrease in mortality. We never proved an increase in mortality, but we certainly excluded any benefit. So I was giving out a useless therapy that may in fact have been increasing mortality, certainly had lots of adverse effects with no benefit. Why was I doing this? Well, look at the right side of the slide again, the recommendations that were appearing as these data were accumulating. Once again, lots of expert disagreement, but most of the experts, as the data were accumulating, were recommending it. And that's why I was giving it. So wide expert disagreement and experts a decade behind the evidence, or making recommendations that completely went against what the evidence would have been telling them. These are old stories. They ended in 1990. Something happened around 1990 that changed the picture. Experts still disagree with one another. They still get things wrong, but perhaps not as egregiously so as what you've seen in these stories. Anybody want to take a guess at what happened in 1990 that changed the picture to prevent this sort of thing happening in the current environment?
Your pioneering work. I'm just sucking up to the speaker.
The internet, no. The internet was I would say, the problem. What's the problem with guessing the internet? The problem, I would say, with getting the internet is the internet overwhelmingly has misleading information rather than accurate information. And so the internet, and nobody knows how to, well, some people do know, but in general, people do not know how to distinguish what is the misleading stuff from what is the stuff that is actually accurate and helpful. Did I know? Back in 1990, I was just getting started. I was not the guy who could make the, I actually participated in the big advance.
The design of RCTs and systematic reviews?
Systematic reviews, okay? Systematic reviews and meta-analyses. Before 1990, there weren't any systematic reviews and meta-analyses in the literature. It only got started about 1990. And I would argue that if the cardiologists had seen this, they would have said, whoa, wait a minute, let's give out the thrombolytic therapy. If they seen this, they would have said, whoa, wait a minute, let's stop giving out this lidocaine. Okay? So systematic reviews and meta-analyses summarized in the forest plots that you folks are now familiar with have made a huge impact in preventing the sort of mistakes that we see here. So, third individual I'd like to introduce you to, Brian Haynes. He was the chair of my department in McMaster, which was then clinical epidemiology and biostatistics, and he said something about how we go from evidence to clinical decisions. I'm going to, before I go to what Brian Haynes said, the people who laid the antecedents for what I'm going to tell you Brian Haynes said, Hilary Llewellyn-Thomas on the left, who was a professor here in Toronto before going to Dartmouth. She did work on how to find out from people what their values and preferences are. And Annette O'Connor on the right, who had her career in Ottawa, she laid the groundwork for shared decision-making. But what Brian Haynes said, which was built on what Hilary and Llewellyn-Thomas and Annette O'Connor had done, was to say, in this paper in the BMJ in 2002, evidence does not make decisions, people do. And that underlies the third somewhat ironic principle of evidence-based medicine is evidence never tells you what to do. It's evidence in the context of people's values and preferences. And to illustrate that, I'm going to introduce you to someone else, P.J. Devereux, who is the guy leading the world in terms of changing perioperative medical practice. But before he did that, he did a study that I'm going to tell you about. And I'm going to enroll you in participants to replicate Dr. Devereux's study. So listen carefully, because you're going to soon be participants in the study. And Dr. Devereux took people with atrial fibrillation who are at risk of stroke, increased risk of stroke, and he took a particular population where in 100 people are going to have 12 strokes, 6 major and 6 minor. Anticoagulation would decrease the strokes in 100 patients to 4. They'll prevent 8 strokes, 4 of them major and 4 of them minor strokes. And the question that he asked his patients and his clinicians, and I am asking you now, how many serious gastrointestinal bleeds would you tolerate as a patient or advising your patients as a clinician and still use anticoagulation? Well, people have to understand, to answer that question, what it is to have a major and minor stroke. And this is how Dr. Devereux characterized it. So a minor stroke, you suddenly can't move or feel an arm and leg, difficulty expressing yourself, no pain, admitted to hospital, weakness, numbness, and understanding improved, but you still feel weak and numb, you're able to do almost your activities. So you're limited in the rest of your life, but you're basically able to do most of the things that you'd like to do. On the other hand, a severe stroke, much worse. Unable to move one arm and leg, cannot swallow or control your bladder and bowel, unable to understand and talk, admitted to hospital, can't dress, can't walk, nurse feeds you. After 1 month, a little bit of function in one arm, but you remain limited and dependent on others for the rest of your life. Bad news to have a major stroke. So now that we understand what a stroke, what about a major gastrointestinal bleed? You feel unwell for a couple of days, suddenly you vomit a lot of blood, very frightening. You're admitted to hospital, doctor carries out an endoscopy, you receive sedation, don't need an operation, get blood transfusion, you stay in hospital a week, and then you go home and gradually recover. So those are the major and minor strokes, those are the gastrointestinal bleeds. And so back to the question. Question is, 100 people, 12 strokes, half major, half minor. Anticoagulation decreases it by about 2/3, 8 fewer strokes, prevents 4 major strokes, prevents 4 minor strokes. Anticoagulation increases serious gastrointestinal bleeds. How many gastrointestinal bleeds, given the reduction in 8 strokes, 4 major, 4 minor in 100 people, how many serious gastrointestinal bleeds in those 100 people would you tolerate and still use it?
Are you a study infant or are you an investigator?
You are a patient or a clinician.
Okay.
You can, if you take care of patients in this situation, you can think of it as a clinician helping a patient make the decision. If you're not a clinician looking after patients in this situation, think of yourself as the patient facing this choice of what risk of bleed would you tolerate. Okay? Good. You'll have a chance to express your opinion again. Any questions? Any questions about what about answering this? Or are we okay? Okay, we're okay. Okay. How many would say 5 or fewer bleeds? In other words, more than 5 bleeds, no anticoagulation. Anybody would say 5 or fewer? A couple of people, a few people. Okay. How many would say up to 10? Up to 10, and once you voted, don't vote again. The up to 10, but no more than 10. How many up to 10? Okay, maybe a quarter at least of people. Okay, good. How many up to 15? How many up to 15? Another close to a quarter of the people. How many up to 20? Anybody up to 20? There's a couple of people up to 20. Anybody over 20? Anybody? Okay, maybe 10, 15% of the audience are over 20. Okay, excellent. So the first thing to note right now in this audience, is the diversity in values and preferences. Some of you are much more stroke averse. People who are really stroke averse were the last group who would tolerate more than 20, and some of you are much bleeding averse. Some of you were so bleeding averse that you wouldn't only tolerate 5. Okay, so in this audience, what we call the differences in value and preferences, great diversity. Some of you are much more stroke averse, and some of you are much more bleeding averse. And here's what Dr. Devereux found. The patients are in red, the physicians in the other color, and look at the physicians, a flat distribution. Not a little bit different distribution. There were more at the upper end, a little bit more at the upper end, but not too far from the flat distribution. And when I'm with internal medicine audiences, I tell this story a lot. It's a good story to illustrate values and preferences, and I've replicated Dr. Devereux's findings over and over. Look at the patients. The 2/3 of the patients are ready to tolerate 22 bleeds. 22, that sounds a bit of an odd number. Why 22? The reason for 22 was that Dr. Devereux, when he designed his study, was thinking like a clinician, and he thought nobody would go higher than 22. Had you given them the chance, they would have. Okay? So now we see that there's wide diversity among the clinicians, just as there was wide diversity in the people in this room. But in general, the patients are much more bleeding averse, much more stroke averse and much less bleeding averse than are the physicians. So one message is, we are much better off if we want to serve our patients using their values and preferences rather than the clinician's values and preferences. But there's a second message, and that is that although 2/3 of them are very stroke averse and not very bleeding averse, there are a few people at the other end who are more like the clinicians, bleeding averse and more stroke averse. So if you really want to get it right, you have to tailor it to the values and preferences of the individual patient. And thus, we have the 3 principles of EVM. Some evidence is more trustworthy than others, and I presented an initial simple hierarchy of deciding what is more or less trustworthy. Second, the best clinical care requires systematic reviews of the evidence, and we've seen how the smart cardiologists went terribly wrong before they had available to them such summaries. And finally, the ironic third principle of evidence-based medicine: evidence by itself never tells you what to do. It's always evidence in the context of values and preferences. So, next gentleman I would like to introduce you to is Andy Oxman. Andy Oxman worked with us in Hamilton for a decade or more, and then went to where he is now, which is in Norway. And he came up with the idea of a system of rating certainty of evidence and moving from evidence to recommendations, which we have called GRADE. And when he did this, there was a chaos of systems available. We thought, if we develop it properly, maybe it would be widely adopted. Who didn't know whether it would work or not? It's worked pretty well. Over 110 organizations worldwide have adopted GRADE. I'll come back up to it in a second. So you see, upper left-hand corner, World Health Organization, American Thoracic Society, American College of Physicians, the National Health Service in Britain, the Cochrane collaboration. And how many people in this room look after patients? Okay, most people look after patients. Of those who look after patients, how many use UpToDate? Okay, almost everybody who put up their hands looking patients use UpToDate. The worldwide, by far, I can go anywhere in the world, academic audience, I get a very similar response. Extraordinary uptake of UpToDate, which has over 10,000 graded recommendations. So the number one user of the GRADE approach is UpToDate, which is the number one resource for clinicians. So we've been very happy with the uptake of GRADE. Here's how GRADE deals with the certainty of evidence. You saw Dave Sackett's simple hierarchy. Here's a new hierarchy. So if you look at the right side, high, moderate, low, and very low, those are the four categories of certainty or quality of the evidence. Randomized trials start as high certainty, but they may not end up as high certainty. They may suffer from risk of bias, lack of concealment, blinding, lots of patients lost to follow-up. They may suffer from imprecision, wide confidence intervals due to small numbers of patients and small numbers of events. Indirect evidence. I work as a secondary care hospital-based internist, and a lot of my patients nowadays are over the age of 80, and not in a considerable and increasing number are over the age of 90. I try to base my practice on the results of randomized trials, but there's not too many patients in those age groups who are in the trials. The trials thus provide indirect evidence. The trials in the younger patients provide indirect evidence from the older studies, and as a result, I'm not as confident using the results of those trials in my older patients. Inconsistency, the results different from trial to trial, and we don't know why. Lowers our certainty of evidence, and we also worry about publication bias. So, of those of you who look after patients, can you think of any interventions that you use that you are sure benefit patients, even though there are no randomized trials? Yes?
The application of AAV SMN1 in infants born with type 1 spinal muscular atrophy.
That sounds very convincing. Okay, I know nothing. You may be right, you may be wrong. Okay. Who can think of some more simple, something in adults in particular? Yes, Guyatt.
I can remember back from my days streptomycin for meningitis, or an antibiotic for meningitis.
Antibiotics in general for infections, okay? So antibiotics we don't know which antibiotics to give sometimes, we don't know what dose, we don't know how long, but we know in general antibiotics for serious infections. Yes, any other? I saw a hand in the back.
Mine was the same.
Same, okay.
Insulin.
Insulin for diabetic ketoacidosis, okay, good.
I'm going to put in health behavior like smoking, alcohol recommendations.
What would your recommendation be?
Well, I think the recommendation right now is to not drink or reduce your...
Yeah. We're talking about interventions. Do you think telling people to stop smoking stops them smoking? Not much. Okay, all right.
Uncontroversial is right. That's an intervention.
Yeah, it's uncontroversial to tell the patients to do it. Unfortunately, it does very little, if any, good. So the...
No, I'm saying like that's the... I think... Yeah, no, I'm just saying that that's one step. People are giving recommendations that there may not be evidence.
Yeah, so the point I'm making here is that stopping smoking for sure improves your health. How you get people to stop smoking is another matter. Yes?
Transfusions for acute bleeding.
Transfusions for acute bleeding depends when. If you do it out of hospital in somebody with an acute trauma, it kills you rather than helping you. So it depends on the circumstances in which you
Dr.
give it.
Hebert is a real leader.
Yes, and Dr. Hebert is nodding his head. I'm right about what I just said. Okay, so it depends. So you got to be careful. It depends. However, I'll give it. Yes. Pardon? Yes, hip replacement. Okay. So hip replacement. How about cardiac resuscitation after cardiac arrest? Everybody used to die. Now some people, not too many necessarily, but some people get to insulin for, we said insulin for diabetic ketoacidosis, dialysis for people in terminal renal failure, putting in a tube and breathing for people who are about to die of respiratory failure. Okay, what do all these things have in common? These ones, what do they have in common?
In extremis?
Big effect size.
Big effect size, okay? Hip replacement, in extremis for some, not for hip replacement, but yes, very large or very large effect size. So large or very large effect size or a dose response curve, most of the time large or very, they move up the certainty of evidence. Okay, so then we have randomized trial starts high, observational studies start as low, but if you have a large effect or a dose response gradient, particularly large effect, it can move it up. So that is now our new hierarchy of evidence. Dave Sackett's simple one at the beginning. This is now our new, much more sophisticated, and we think very useful hierarchy of evidence for grade. And here's how grade summarizes the evidence in something called a summary of findings table. On the left in the first column, you have the outcomes of interest for baricitinib in patients with severe or critical COVID, mortality, mechanical ventilation, and so on. Moving across to mortality, you have the relative effects, and you have the absolute effects. What's more important for patients, relative effects or absolute effects? Who thinks relative effects are more important for patients? Who thinks absolute effects? Okay. Who's not sure? Okay. Nobody is willing to admit not sure, and those who put up their hands are right. Absolute effects. So the next columns are the absolute effects. They're the crucial things from the patient point of view. In this case, 4.5% point estimate reduction in mortality with baricitinib. Next column, the certainty of the evidence. The next column, a plain language statement following from the effect and the certainty of the evidence. That's how grade suggests presenting and summarizing the results. I think it's very useful. Okay, now that's what grade does about evidence. What about moving from evidence to recommendations? Moving from recommendations, we have two classes of recommendations, strong and weak or conditional recommendations. Strong recommendations when the good things about an intervention clearly outweigh the bad things, or the bad things about an intervention clearly outweigh the good things. What can move you from a strong to a weak or conditional recommendation? One, you only have low certainty in the evidence. How can you be certain that the good things are better than the bad things when you aren't certain about the good things and you aren't certain about the bad things? Or close balance between the good things and the bad things. And we like this two classifications, strong or conditional recommendations, because it has clear implications. One way of looking at it that we think is very useful, we make a strong recommendation when all or almost all fully informed patients would make the same choice. We make a conditional or weak recommendation when, hopefully, if the panel has got it right, the majority of patients will choose the recommended course of action, but because of different values and preferences, others would choose the course of action not recommended. This has interaction with the patient. There is one question when I go around the world talking to clinical audiences, one question I ask where I always get the same answer wherever I go, and I always get the same answer from everybody in the audience. And that question is, do you have enough time to spend with your patients to make you comfortable with all your patients and you've got the right amount of time with them? Everybody says no. Everybody says no. Everybody in the world says no. Which means we are time constrained, which means we have to ration our time with patients. And the strong versus the conditional recommendations help you to ration. If the panel has got it right, it's a strong recommendation. If you went through a full shared decision-making exercise, everybody or almost everybody would make the same choice. Probably not a great way to spend your limited time. On the other hand, a conditional recommendation, if the panel has got it right, means that the right choice differs across patients, and though that is the situation when you should be doing a shared decision-making exercise. And finally, use of decision aids. Shared decision-making isn't easy. We need decision aids to help us. Probably not a good, again, expenditure of time with a strong recommendation. Everybody's going to make the same choice. You just proceed to tell them what you think they should do, but a weaker conditional recommendation would be the aid. All right, so guidelines, which clinicians find very useful, are for average or typical patients. Can't be any other way. However, we have learned that patient values and preferences differ, and it would be nice to be able, at the point of care, to engage the patient in shared decision-making. Victor Montori, who studied with us and is now at the Mayo Clinic as a professor of medicine and is leading the world, in my opinion, in shared decision-making. He's a diabetologist, and as a diabetologist, He has dealing with people and asking people about their preferences, about what nowadays we have many different treatments, what they would like. And what he does is he puts on cards the different outcomes, weight change, hypoglycemia, lowering the blood sugar, daily routine, sugar testing, cost, and how each of the treatments do. And he says to the patient, pick one card, pick one that you're most interested in. What do you think the most popular first choice is? Weight change. 40% of people. And they may then say, what about the daily routine? And then they may say, what about the cost? And in fact, they may ask for all 6, but they never do. Typically 4 at the most, often 3, sometimes 2. And at the end of that, they say, now I have my choice. And we will now see if it works, and it should. A video clip, yes, usually I just have to press.
So yes, I agree. We need to make sure your sugars are better controlled. So that means we need a new medication. So which aspect of your next study's medication do you want to discuss first?
Weight change.
Weight change? I'll let you review that.
Okay. So this is the one that I'm on.
Yeah, you're already on metformin.
Well, this one looks good to me.
Yeah, that one is going to help you lose some weight.
Yeah.
What aspect of that medication would you like to learn about next?
I'd say the daily routine.
Sure. Yeah.
Oh, so this is an injectable?
Yeah, it's actually very easy. There are a couple of pens that have needles, and you inject a needle into your belly and do that twice a day before your meals.
Yeah, I don't think I really want.
You don't want to go needles?
No. I'd much rather just pills. So this is okay. Well then, so this sulfonylurea is?
That's the next best one for you in terms of the weight, huh?
Yeah.
Well, that's a daily pill, so that you can start with just 1 pill a day.
Yep, and just 30 minutes beforehand?
Yeah, usually 30 minutes before breakfast. Would that be okay?
Yeah.
Okay, well, the other thing to consider is that sometimes they can give you low blood sugar, so we're going to ask you to monitor a little more often than you're doing right now, but otherwise that would be okay. If you were to change your mind after you go home, I'll give you this pamphlet. It has the same thing as the cards, so as you're using the tablet, if you find that it's not what you're expecting, you know, review this again and give me a call and we can discuss it again.
Okay.
All right, thank you.
So, brilliant innovation in shared decision making, evidence-based shared decision making in a minute and a half. Doesn't always go quite this smoothly, but nevertheless, great facilitation of shared decision making at a really innovative decision age. Next two folks I'd like to introduce you to, Deborah Cook and Maureen Mead. They give examples of clinical areas in which thought leaders have brought evidence-based medicine to fore. These two are critical care physicians and have led the charge for evidence-based medicine in critical care. And particularly, Deborah has done something quite marvelous, I think. She has developed a project called 3 Wishes, where the clinicians and the caregivers approach patients and family and say, these are people who are known to be terminal, they haven't got long to go. What can we do to make your end-of-life experience for patient and family more human, more satisfying? And in particular, for patients to honor their inherent dignity, for families to humanize the dying process and support them in grief, for the clinicians to inspire a deeper sense of vocation. Wishes may be those of the patient, family, friends, or clinicians. They may be very simple things like to bring a bouquet of the patient's favorite flowers to the bedside. They may be something that requires a little more work to engineer, like having a marriage ceremony conducted at the bedside. Deborah is, of course, an evidence-based clinician, so she wanted to find out how the impact she has done, she has led, and other folks have done multi-center mixed method studies, finding that what matters most at the end of life is usually simple. Eliciting and implementing wishes helps to personalize the dying process, brings comfort and meaning to all those. 3 Wishes product would Three wishes process gives voice to the family and calls forth physician compassion. End of life. This approach has been widely adopted. Marvelous evidence-based innovation. Next person that I would like to introduce you to is Per van Beek. Per van Beek was from Norway, was with us for just a year, returned to Norway. When he was with us, he helped us on a particular clinical practice guideline that I led for the American College of Chest Physicians. And he thought we produced a great guideline, but Per was skeptical. He said, is this guideline that we're using based on grade available, useful, and understandable for clinicians? Maybe not. Is it suited for integration into electronic medical records, textbooks, and adaptation? Definitely not. Is it sufficiently up to date? Maybe in the day it appeared, but as typical for guidelines produced by organizations, everybody's exhausted at the end and they wait 2 or 3 years before doing it again, by which time everything becomes out of date. And does it facilitate shared decision making? Not at all. How to make grade irresistible for clinicians, patients, and developers. He decided that the solution was magic. Magic stands for making grade the irresistible choice. And in doing this, one of the messages that came out of that was, guidelines get out of date. What we need is what people are now referring to as living systematic reviews. We keep it updated. Living guidelines, we keep it updated. And to show how it could be done, Per led the MAGIC group in negotiating with the BMJ and producing BMJ rapid recommendations, where we identify practice-changing information, very quickly do or utilize, if it's available, systematic review, very quickly get a guideline panel together, go through a trustworthy guideline process, goal in 90 days from the identification to the information to the guideline that is then published in the BMJ. It started in September 2016, and here was what we addressed in the initial one. So what helps with this, and where the real magic comes, is in the MAGIC app. The MAGIC app uses building block principles to create a structured platform for creating the guideline and using it. And that then allows us to put it on your smartphone, integration in the electronic medical record, easy adaptation, and decision aids for patients and clinicians. And particularly with the last individual I'm introducing you, Thomas Agaritsis. He was with us for 3 years or so. He's now returned to his native Geneva and is working very closely with Per in the MAGIC initiative. And he's done a lot of work on decision aids, and we now can do semi-structured, automated use of the decision aids based on, and we can do it because of systematic reviews are structured on grade principles, because of Victor's innovations in evolution of decision aids and clinical encounters that I told you about, and because of the MAGIC app. And I'm now going to go to final little bit of this talk, EBM in the time of COVID, where I think we have been very successful. And one of the successes led by 2 young people from our institution, Reed Semenchuk and Romina Brignadello, put together a living network meta-analysis. Network meta-analysis the last 15 years or so, big innovation within EBM. The prior systematic reviews, one treatment versus another, now simultaneous comparison of multiple treatments. And they have developed a team of 60 young methodologists who are supporting them, and they've been processing at the height of the trials done in COVID, 20 trials a week, putting them into a network meta-analysis and updating them very quickly. And those meta-analyses informed the World Health Organization. MAGIC has partnered with BMJ and the World Health Organization So now the World Health Organization COVID guidelines are produced and published by the WHO, and on the same day they're published in the WHO, they are published in the BMJ for BMJ Rapid Rex. So now simultaneously appealing for these two quite different audiences, the WHO audience and the clinical BMJ audience. And I'm going to, I hope, show you the magic in the Magic app. Okay, so here with the mouse click, I've gone to the WHO guidelines for COVID. And I go to recommendations. We have recommendations number 7 there, recommendations for non-severe COVID, and then separate recommendations with severe or critical. I'm going to go to the non-severe. The most effective treatment for people with non-severe COVID is nirmatrelvir ritonavir combination Paxlovid. And if you can see in color-coded recommendations, for patients with non-severe COVID-19 at high risk of hospitalization, there's a strong recommendation in favor. For lower risk patients, where the benefit is less, it becomes a conditional recommendation in favor. And since now most COVID is a very mild transitory illness, for patients with non-severe COVID at lowest risk of hospitalization, it's a conditional recommendation against. And what the Magic app does, so the clinician can just say, okay, good, you've told me for what to do. That may be enough. But clinicians may be interested in the research evidence, and if they are, they can now go to one of these summary of findings tables. You remember I showed you one of these that tells the relative effect, absolute effect, certainty of evidence, and the plain language summary. They can go, if they're interested, to the evidence, what we call the evidence to decision grade framework, where they will see the benefits and the harms, the certainty of evidence, values and preferences, and resources and other considerations. They can find the justification for the recommendation. They can find practical information about the route, dosage, and duration. Some clinicians may say, tell me what to do, and then just go to the practical information. Who cares about the evidence? I just want to know what to do, and I want to know how to do it. And this allows that option, or it allows. And for those who want to actually involve their patients, it gives the option of decision aids. And so we can view the decision aid, and you can see there's 3 mortalities and 3 admissions to hospital. Why are there 3? 1, summarizing the evidence for the low-risk patients, very low risk of dying and hospitalization, the moderate risk, and the high risk. Because you'll remember the low risk, it was a conditional recommendation against, moderate conditional for, and high risk. So that's the most interesting one perhaps is and I should have said you had all the outcomes up here. Now it's when you're with the patients, it's the Victor Montori approach. Which outcome are you interested in? And it's shared decision making. You may guide the patient because you as the clinician know the action with these things is really, with these drugs, is reducing the admission to hospital. So here you have in 1,000 patients, 25 fewer hospitalizations, 2.5% difference, from 30 to 5, and patients may be a bit numerically challenged. So we can go to this presentation. There's 1,000 faces or 1,000 representative figures there. The black and the orange represents the 30 people who are going to be hospitalized without nirmatrelvir. The orange is the 25 out of 30 who will not be hospitalized if they receive nirmatrelvir, or they would have been hospitalized otherwise. So that then is the Magic app, the platform that we think is really the answer is yes. So it's available. If you are an individual user, it's available to you. Okay, EVM in the time of COVID. Unprecedented rapid production. The international community mobilized. They used a platform trial that allowed extremely efficient production of evidence. From the start of 2 years after the start of we had randomized trial evidence of 3 effective treatments for non-severe COVID and 3 classes of agents for severe COVID that were of benefit in lowering mortality. Extremely effective. And then the summarization of the evidence in the living network meta-analysis, and then in guidelines, and then this nice dissemination with at least one set of the guidelines for the WHO and the BMJ. Really, if we can keep the world working like this, this would be great. So, in summary, conclusions, the 3 principles of evidence-based medicine are widely acknowledged. Hierarchy of evidence, we had a simple one, we now have a much more sophisticated one in grade that we think is very valuable. Need for living systematic review, summary of guidelines. If we're going to serve our clinical community, we need to update them very quickly, the way we did with COVID. Importance of values and preferences. 3rd principle, evidence by itself never tells you what to do. It's always in the context of patient values and preferences. Point of care decision aids the ideal solution. COVID shows full potential, rapid accumulation of trustworthy evidence, rapid incorporation into state-of-the-art evidence summaries, and rapid production of guidelines helping patients, helping clinicians optimally manage their patients. So there is the end of the presentation. I'm happy now to take questions. Anybody question or comment? Yes.
Thanks very much. That was an excellent talk.
Thank you.
Very informative, very important, topical.
Thank you.
My question is probably very difficult to answer. I just wondered if you could comment. So in a period of almost severe disinformation and misinformation, how will EBM sort of guide our patients when what they're ingesting is probably not accurate?
Right. Okay. So you are right. It's a difficult question to answer, and it's a particularly difficult question. But I think the sciences that might help me to answer this might be political science and social anthropology and social psychology, and my expertise in each of those is 0. So as a result, I'm not a great person to answer that question. I will say that it is very, you said it would be a difficult, even as a naive individual, I agree with you, it's a very difficult question to answer. And I believe I do, within the world of evidence-based medicine, know what the long-term solution is. Andy Austin, the guy whose idea was great, has in the last 10 years kind of less great than the rest of us, and his work has been in what we call informed health choices. And he has been conducting randomized trials of school children as early as grade school, teaching them how to make informed health choices. And he has found in his randomized trial that it is possible to teach kids how to make informed health choices. His first randomized trial, he started with an easy population. School kids in Uganda. Anyway, that was his first trial, and he showed you could do it in Uganda. He's shown you could do it in other places. That's the long-term solution to the problem, is start teaching these principles of informed health choices at a very early stage, and he has shown it's possible. You're welcome. Yes.
Thank you. That was a very engaging lecture.
Thank you.
I wondered about the situations where I'm a cancer surgeon and researcher, and we now have this situation where we understand that cancers are just a whole bunch of incredibly rare diseases, and many of them are ultra-rare diseases as we start to sequence patients, and we have all of these new therapies coming down the pipeline that are very targeted. So the possibility of doing a randomized controlled trial actually becomes impossible. And so I'm just wondering, do you have a sense of how we would move forward in an ecosystem like that, where you have, potentially 5 different therapies available, and how do you know which one to give, or
Well, um, you may not be able to do randomized trials, but surely you've got to give the interventions to people, the particular interventions to people you think are going to benefit. And if it turns out you have, so I earlier said about how with observational studies you can have high certainty evidence and big effects. So for instance, if 80% of the people used to die within 6 months and you have a population who you identify with genetic structure or something else that you think are the ones who are going to benefit, and now 100% of them survive more than 6 months, you have a huge treatment effect and you know that that is useful. If you have marginal benefits, so obviously it's only going to be low certainty evidence relative to historical controls unless you have these huge treatment effects. And if you don't, sorry, you only have low or very low certainty evidence, and maybe you should do some international thing where you do get enough patients that you can test it. So if you have huge treatment effects in comparison to control, you may have moderate or high certainty evidence, and that would be a way of moving forward. If you do not, you need to hesitate. You may still move forward, but on the basis of low or very low certainty evidence, where you have competing resources, there are harms associated with it, perhaps not such a good idea. Does that help?
Yeah, I think so. I think just the challenges of the way clinical trials are regulated makes it nearly impossible to do a clinical trial in that kind of situation, unfortunately.
Well,
it's just the realities of our
if
system, unfortunately.
And that shows that we need changes in the organization of how we do trials to make that possible.
100%.
And I hope, my colleague P.J. Devereux is leading the ACT consortium to try and make the sort of changes that are necessary. In the interval, you can use observational studies, but you're going to be low certainty evidence, making it much harder to know what to do.
Absolutely.
Anyone else?
There's a reception after that people can approach you.
There is a reception after where people can approach me.
Yes.
Thank you again. Thank you for all the success of these talks. It requires audience engagement. Thank you very much for engaging. It's been fun talking to you.
For entertaining and educating. Don't go yet. Final word.
And after this, there's no reason to applaud for a third time.
Okay, so that, Gordon, was a great lecture. An earlier panel session, thanks to Gordon, of course, Alex McKenzie, Jason Berman, Duncan Stewart, Paul Herbert, Julian Little, and Denuka Radishakhan, as well as the audience for their contributions and participation. The Friends of CIHR especially wish to thank our Ottawa lead sponsors for this event, the University of Ottawa, the University of Ottawa Heart Institute, the Bourrier Health Research Institute, the Royal Mental Care and Research Center, and the Institut du Savoir. The Friesen Prize and related events today are organized by colleagues at the Friends of CIHR, so I especially want to thank all of our executive and board members, and we have two here in particular, Alex McKenzie and Duncan Stewart. So we very much look forward to our next planned visits across the university.